wounds. That is what we are going to see today. So the overview of the session is today, what is wound and the overall classification, what exclusively about palliative care wounds. In palliative care, what are all the type of wounds we will see, what is the assessment tools, what are all the principles and management. So as you all know, the wound would be like defined as any break in the skin or epithelial tissue, right? And that is called, either it could be accidental or surgical. That is what we define as a wound. If you see the broad prevalence in the wound, actually the acute wounds are more common. It is 10.5 per thousand population, but the chronic wounds are less, 4.5 per thousand population. But as a healthcare professionals, we all know it is easy to manage acute wounds because you know the healing process of acute wound. Either it is accidental or surgical, you know the wound will heal. You know the processes of healing, the stages, everything. So easy to manage, and the protocols are standard. We can able to do. But when it comes to chronic wound, it is always challengeable. It is very difficult to handle, and you have a lot of complication. The symptoms are aggressive, and it doesn't heal. That is the problem. So today my focus is how to handle the chronic wounds. That is what we are going to see. So in palliative care, if you see, the wound is very important. Why it is important? Because it is very complex and dynamic, and it is evolving the balance between not only the patient and almost also the patient caregivers. So it affects the entire circle of the care because of the symptoms and because of the burden and because of the need from the patient. So it's always huge challenge to handle a palliative care wounds. So when you look into the type, there are different types because unlike the traditional care, the goal of palliative care wound is necessarily it's not to heal the wound. Here the goal is to manage the symptoms of the wound and make the patient more comfortable. So some chronic wounds such as caused by cancer, that is what malignant wounds, right, which cannot be healed. That is very challengeable in palliative care, and most patients are terminally ill patients and non-communicable disease, chronic diseases, and they prone to develop pressure ulcers. That is more than 40% in palliative care. Apart from that, there are some of the wounds which is ulcerative wounds. I'll talk about some diabetic wound, leg ulcers, all these things we'll see in this session today. If you see, this is what one day one of our patients said, and that is what I put it here. So this is the real life experience. The drainage and the order is so bad. I am embarrassed to go out, right? I feel like family doesn't want me to be around because of all these things. I don't want to be or either. This is what the patient said one day when we were on the rounds time. And the family member, then when the counselor asked the family member, they said, we are helpless. We don't know how to help. When I go, I love my father. It is the daughter said, love my father. But when I go near to you, I feel so nauseated. No, I just can't tolerate to stand next to that. It is not that I hate them, but I don't know what to do. This is what every day we face when we are in palliative care setup. That is why it is important. Why it is important? Because there are different factors will affect the wound doesn't heal. Why the patient comes to palliative care? Because of wound management means this wound is not healing. They don't know what to do. That's why they come. So why it is not healing? The first one, when you see the patient-related factors, when you see the patient-related factors, it is because of the pathology and because of the patient, the wound location might be the different place which is not allowing the wound to heal, and the patient might be allergic to some medications, and the patient may have severe pain because of the wound. The patient might have a lot of comorbidities which is not supporting the wound healing. That is one factor which is patient related. The other factor is wound related. As I said, the wound anatomy, wound bed, and the necrosis of the wound, and all these things, the wound related factors. When you come, the next one is healthcare professionals. This is you and me. how much we are skillful and knowledgeable to assess the wound, to evaluate the wound. Because when you assess and evaluate, if your diagnosis is proper, it's easy to plan, to go with the treatment. But you don't know how to diagnose, you don't know how to plan your treatment, you can't provide any intervention to the patient. So we also will have a problem, unable to diagnose properly which kind of, what is the stage, what kind of wound, and all those things. Other one is healthcare sector. So that is because the availability of healthcare sectors nearby patient places. So what happens? All these reasons, right? When the patient, makes them to prone to develop a wound will not heal. So if the wound is healing, it's okay. They can go with the maintenance process. The wound will support. The wound doesn't heal, again they have to start the circle. So lot of evidences shows that palliative care increases the patient's overall satisfaction within the care they receive. That is what they seek for palliative care. So once the patient comes to palliative care, when they seek the wound management, what is our goal? Okay, so again our goal is, we are very clear, we are not going to heal the wound. Address, our focus is on comfort. Comfort is focused on symptom management. Whatever the symptoms are there, let us discuss in the coming slides. Whatever the symptoms are there, that will be controlled. And based on the symptoms, inform the patient and take their consent, what the patient want. I think you all would have studied about pain management and the assessment tool, right? PQRST. The same assessment, no, initial, when you take history, apply for this also, wound assessment. So you need, by then, when you apply that PQRST, you will understand what the patient want, what is the cause, and all the reasons you will come to. Based on that, make an informed decision between the patient and the healthcare giver. So it is always will be a patient-centered care. So then you focus on quality of life. Even the patient is on the end of life, right? Till last breath, how much ever possible, you have to provide a comfort and quality of life to the patient. This is the overall goal for the patient with when the patient comes to palliative care. Now, the patient is there, the patient came, so you set a goal, but you need to know where to start, right? Where will you start? Start from the history. When you start the history, start with your PQRST and look at the wound bed, how the wound is, which is very important. As a healthcare professionals will come to know, doctors, how if the wound is fresh. So it should be, the wound bed should be pinkish red in color. If it is pinkish red in color, it is a healthy wound, right? So it gives an idea either the wound is going to heal or the wound is does not go to heal. So all these things. Then you come to a conclusion. What is the evidence-based practice? What I can use for this wound? Look at the risk. If I use this, what will be the risk? Either the patient will be benefited or non-benefited. All these things you have to plan ahead before you go and see the wound. So let me start with wound assessment. Before you go to any management, let us see the assessment. So this assessment will start from the observation. Look at the wound, start asking questions, do the physical examination, then you can send the culture if there is any infection or something. So it gives an idea how much is the wound extent and how much is the severity, what will be the burden. That gives an overall idea for you and plan for your intervention. So the aim for the wound assessment is you will identify the skin breakdown. Okay, what is the cause for the skin breakdown and what are all the risk factors? Either the patient is because of the disease or because of accident or because of surgery, it became chronic, or because of the comorbidity, the wound is not healing, all these reasons. And so it gives an idea. Based on this, you can treat the underlying cause of the symptom, and then you can choose the appropriate treatment and control the wound related symptoms. So kind of the patient might have bleeding, the patient might have exudates or whatever it may be. And the goal here, the major goal is you should not, already the patient is there with the wound. So your goal should be the patient should not have a bleeding, the patient should not have a further infection, or the patient should not have further deterioration. These are all things you should keep it in mind. So identify what the patient expects. That is what in the PQRST scale, recently they have added UB. So understand the patient, value their goals. So that is what it's added, and provide the psychological support based on the patient wish. So these are all the parameters. Understand, as discussed, understand etiology and where the wound is located, which is very important. You have to find out and write the basic assessment should be done, and how the wound is, the extent of the tissue loss and the stage of the wound. If it is pressure ulcer, you know what is the stage of the wound and all those things, and what is the phase of healing and size of the wound, because you can plan either this wound will heal, or if it is one patient we have seen came with CA breast, the wound is from the mediasternum to the spinal cord, huge wound. There is no possibility of healing, right? It is ulcerated, fungated. It's very difficult to heal the wound. So you can identify that. And is there any undermining or tunneling is there, and condition of the wound bed, like I said, and exudates. If there is exudates, need a frequent dressing, and need to start the different things, and peri-wound skin. And is there any pain, which is the major problem with the wound? Most of the pain, most of the time, you can't control the uh, the patient will have severe pain. Unless you control the pain, it's very difficult to do the dressing for the patient. This is one of the scale, which is called a time scale. So it's a very good scale, will help you to assess either the wound is going to heal and it's not going to heal. I always use this scale. I have put in my presentation uh, how I applied wound scale for my patient. How did I come to a conclusion saying that the wound will not heal? So it gives an idea about the tissue management, inflammation or infection, the moisture balance in the wound, and the surroundings. Okay, all these things will be decided by this scale. This is called a TOVA scale. TOVA scale is all about the wound bed and the edge. So what is the tissues type, exudates and infection, and the edges. Sometimes the edges are macerated. There will be hyperkeratosis. There will be edema, and the wound will be dehydrated. You can see the undermining, all these things. So this will be helpful to understand the wound bed and the edges. That time scale will be helpful to assess either the wound is going to heal or not. Apart from all these things, I will also talk about pressure ulcers in detail. When I talk about wound, this is one kind of wound which is called scale wounds. This is scale means skin changes at end of life. This will be given by the expert panel. Paper is published. So this panel coined the term, these people coined the term in 2008, which is called scale wounds. So what they were telling is, so the wound occurrence, it's the patient, when the patient in end of life care, because of the complication, there will be a failure of hemostatic mechanism in the end of life. So at this stage, there will be a skin alterations. So such as pressure ulcer. Okay, this one cannot be prevented. This kind of ulcers, okay, this is called scale ulcer, Kennedy ulcer. You can't prevent at the end of life. This is happening, okay, because of the patient response to the care, because you can't provide any care at this stage. So the interprofessional team members and the patient circles to be informed and expectations regarding the patient's end of life objectives. So in this stage, they can't expect any curative possibility, and this could be because of the last 14 days. What happens when the patient is sick? There will be a physiological shutdown. Okay, that is the reason the scale wounds are happening, because the patient doesn't have appetite, weight loss, cachexia, muscle wasting, and low serum albumin, and low hemoglobin, dehydration. All these factors, causes the scale ulcers. So in case if the patient is develop scale ulcers, okay, you have to apply this SOP protocol. See that what is the subjective skin and wound assessment, objective observations, then assess and document the etiology why the patient is getting, and you go with the plan of care. When it comes to plan of care, your care is patient-centered outcomes. So remember this 5 P's in the in case if the patient with scale ulcers. Our goal is here is prevent. None of our patients should get scale ulcers by providing proper position, maintaining kind of nutrition, and all these things would be helpful in prevention. But still, when the patient is towards end of life, when the hemodynamic, the patient condition is goes bad, physiological shutdown of the organs, it may happen. And then prescribe based on the things you can, what you can make the patient to comfort by cleaning the wound, that prescription, and preserve it how much ever the wound has formed. So it is there in our hand. We can prevent the further deterioration, and then you can palliate the symptoms. So whatever the symptoms, the patient might have pain, the patient might have severe malodor, whatever it may be, you have to take away the symptom and give the preference what the patient want. That is very, very important. So on these things, you can educate your, empower the caregivers. So this is how you have to plan for the scale wounds. So assess the wound, goals of your care, remember 5 P's, based on that, educate the family members. Now, so overall, we have seen what is wound, how to assess, and everything. Most of the time, so when you see in palliative care, we happen to see the malignant fungating wounds. It's very common, this malignant wounds, because if you see these wounds, or there is an infiltration and proliferation in the malignant cells into the skin, and it is not only in that, it affects the blood and lymph vessels. If you look into the statistics, the patient with advanced cancer, 5%, they may have this. Metastatic patients, 10%. And if you see the life expectancy, it will be between 6 to 12 months. So that's also, it is very complicated and difficult to assess, and they bleed very badly. Very bad foul smell will be there. How to handle these wounds? So this is the challenge. So the malignant wounds, it's as I said, it is it's a dynamic wound. It's a lack of vascularization, and a lot of anaerobic bacteria will grow. So that maybe that's because of the underlying disease, cancer, and it gives a no environment, micro environment for a bacteria to grow. So the bacteria will grow, anaerobic bacteria. So the patient will have lead to have increased exudates, pain, and severe malodor because of this. For your better understanding, look at this case. So now our patient, she is with CA breast and came with the stage 4. She underwent all the treatment and chemotherapy. Now she was in advanced stage. Three sons, they were no one son, and the elder son also got some chronic disease, bedbound. Second son is a breadwinner of the family. Third son is actually a primary caregiver who's looking after this patient. She came with all the symptoms like dyspnea, breathing difficulty, hoarseness, unable to eat. There is a lymphedema. She was, some most of the time she would be bedbound, and she can able to do. But this one, she had a multiple wounds, and she has got a wound over the even the subclavicular region. She has a mixed pain, which is nociceptive and neuropathic pain. It was radiating the shoulder, neck, and face everywhere. And the wound is very much ulcerated, granulated. She had pain, she had foul smell, exudates, bleeding, everything. So here the question is about not to get cured, but how to live, because she is not going to die immediately. She was with us for 4 months. She is not, you have such a bad wound, you go and die, we can't say, but she has to live. How to live with this wound? That is the breaking question in front of us. So it's in our hand. You have to provide good wound management. Though the which is proper assessment. Okay, as I discussed, I will show how did I do the basic assessment for Siddhamma and make a decision making and plan your care. How are you going to provide care to the patient? So this is how I did a basic wound assessment. So it shows, first look at the site, You can see the side, left breast, the size. I measured length, breadth, and width. And exudates, you can see how shiny the wound is. There is a mild exudates with the order. You can see the wound edges undermining. You can see the red granulation here, necrotic sheet tissue, black color. Sloughs are there. And you can see the epithelial tissue, pink in color. This is what the basic assessment. By seeing this wound, by seeing this, the wound is not going to heal, but you need to have a evidence documentation, how you are saying the wound is not healing. So for this, I used a time scale. Look at here. So this is the time assessment. You can see the lady, 45 years with ulcerated granulated wound, basic detail. And look at the wound score. The tissue more than 50% is necrotized. It's score 2. And inflammation is present. Yes, 1. Mild exudates were scored 1. Absence of epidermis, dermis, you can't see here. So score 2. So the overall wound score is 2. And the general condition of the patient is 45 years, female lady, mental state is good. She is self-sufficient, able to manage, she is eating, and there is no predisposing disease. So the time score is showing 7A. So it is 6 plus 1, 7A. If it is 7, if it is 7 and above 7, it shows the difficulty in healing, the score table. So then what is my plan of a care? So here my plan is twice a day dressing with metronidazole and reduce the pain. Target is to, because she had a mixed nociceptive and neuropathic pain, control the exudates and provide comfort and quality of life to my patient. So it gives an overall idea. I saw the wound, I assessed the wound, I came into a conclusion this wound is not healing. This is my plan for the patient. This is how you have to plan. So the management here is symptom management, for me, the holistic care. And apart from that, in case the patient want to go back home and something, you need to empower the caregiver. The first thing is your focus is on physical problem. Any wound, address the physical problems, then go into the psychological problem. So because the 4 dimensions of palliative care: physical, psychological, social, spiritual. So when it comes to physical, pain, okay, pain is the major issue. Malodor, foul smell, patient with infection, bleeding, exudates. If you don't do anything properly, the patient end up getting maggots. So the pain, basically need to do the proper assessment. You know the scale, pain, different pain scales you would have studied. In case of deep pain, adjust the management. Okay, you have to give systemic analgesics 30 minutes before the dressing. You can give 1 PT dose. If it is superficial pain, so you can give a local application, lignocaine, sensorcaine, even opioid, and loperamide and sublingual ketamine. All these things can be given in case of superficial pain. Then do the dressing, the patient will cooperate. In case of malodor, so in case of malodor, you need to do the deep cleaning. Daily cleaning and dressing should be done. And frequently you should change the dressing because the patient, having severe malodor, and you can start with the antibiotics. So this is very much helpful. The metronidazole, using metronidazole for malodor is very much helpful. How do we use? Means take a metronidazole tablet, crush nicely, powder it. You can see here in the second picture, metronidazole powder. And you can see in the third picture, the Vaseline, the metronidazole powder mixed with the Vaseline. The fourth picture, the nurse is applying this metronidazole pills into the triangular shaped gauze pieces and arranging into the tray. This tray will go for autoclaving. Look into the first picture, and it will be a activated metronidazole gauze. Okay, so it is sterile and you can use directly on the wound. So how I can say this wound is, so this is locally you can apply. If it is not, if at all, if the malodor doesn't come out, then you can start systematically. And it was proved by this ladder. Okay, this is called a sniff ladder. This is a 10 years of clinical research study done by Dr. Reena George from CMC Vellore. So they proved that, made a research, and they have given in palliative care formulary. And this is the ladder. So you can see the smell, nil and faint, foul, and forbidding. how to start the metronidazole. So start with oral metronidazole 400 mg 3 times a day for 7 days. And for the smell, if it is fainting smell or nil, okay, you continue with that and add 200 mg once daily. If it is too much foul, same thing, repeat 400 in 7 days and then continue with 200 mg. And if it is forbidding, and you can same thing 400 mg for 14 days and 200 mg twice a day. This is how you can increase the level, and you can see the impact of the smell. Okay, because if it is only smell, you can see how the patient, the smell maybe with the vaginal this one, and all these things, how the smell will be, and the patient sometimes, if there is forbidding smell, the outcome they will be in a death stage, end of life, all these things. And this is also one more method. So when I said metronidazole topically you can use, metronidazole orally you can start based on the sniff ladder. And apart from that, if the foul smell is so much, there is something called charcoal dressing. The charcoal dressing, we prepare charcoal. See, the commercial charcoal, silver nitrate charcoals are layers are available, which is very costly. This can be prepared, make a charcoal powder, make a fine, like it should be like a talcum powder, fine. You can see how nurses are taking charcoal, drying it, and crushing, swifting, and sending. They will put it in a steel container and send it for autoclave. Then it became an activated charcoal for a wound dressing. So that is for maladar. This is for bleeding. In case of bleeding, your goal is prevention. So prevent the bleeding. So take all the measurements. If the patient is already with the dressing, if the dressing is when you go for the next due and the dressing is so much attached with the what is that in the wound, then you have to soak it. Soak the dressing, leave for 3 minutes, then remove. So what happens? It prevents the pain as well as it prevents the maladar. Then if there is a mild bleeding, use a turmeric dressing. Same with the metronidazole was, put a turmeric powder and give a local pressure for 15 minutes, tight pressure. You can use sulfate powder, hemlock solution, adrenaline 1:10,000 dilution. You can use butrophase, ethamsalate, Tranexa. Locally also you can give, IV also you can give. And if the patient can tolerate, you can send them for palliative radiotherapy. In case of infection, daily dressing with metronidazole. And these three things you have to remember in palliative care. Sorry, typing mistake. 2 times I put slough cutting. One is no slough cutting, no hydrogen peroxide, no betadine. Three things no in palliative care that you have to remember. Coming to the maggots, if you don't manage all those things, the patient end up developing maggots. So apply turpentine. There will be a wound. When you take a turpentine, it has to be soaked with a turpentine oil and put it over the wound. And the maggots will get attached with that gauze. And then you remove it. Then it will be fainted in the wound area. Then manually you have to remove and keep a warm water in a kidney tray. Take manually and remove it. The maggots. And why I'm telling this maggots, if you're the patient with a buccal mucosa, you should be very careful because turpentine is highly irritant. You have to protect the nose and eyes of the patient. It should not affect. Then after turpentine, you can also use mercurochrome 2 to 4% to control, to do the maggots management. So far we have seen about malignant wounds. In case of malignant wound, what is the management? Now come to the other problem in palliative care is pressure ulcer. So the pressure ulcer is the major issue with the terminally ill patient. According to the National Pressure Injury Advisory Panel, it is decubitus ulcer or bed sore. It will be under the bony prominence of the skin. Okay, because of the unrelieved pressure, the patient will get pressure ulcer because it is a major cause of morbidity and mortality, and one of the important measure to take care of patient and improve the quality of life. Even the clinical care in the healthcare settings, because if you see, as a nurse, I'm telling, the Nightingale said very clearly, if the patient is developing pressure ulcer, it is not because of the disease, it is not because of the food, it is not because of the weather, it is because of the poor nursing care. So that's what I was telling clearly. Pressure ulcers are always prevented except the scale ulcers. That is because of the patient body. So it's in our hand how to prevent pressure ulcer. So if you look into the study, evidence shows in the patient with advanced disease or terminal disease, 68% of patients palliative care settings, they develop pressure ulcers, especially when they have stage 3 or stage 4 ulcers are very common with the terminally ill patient. So the nurses will have huge responsibility when they handle terminally ill patient, especially people like us working in the hospice sector. We are in the position of handling all the time terminally ill patients, and always, I'm very keen on nurses to show the zero incidence of not developing pressure ulcers. And so this is pressure ulcers before death in 2 weeks. That's what I said, scale ulcers. So that is because of the physiological shutdown, which can't be prevented. So these are all the major risk factors why the patient is developing pressure ulcers. So there are two reasons. One is pressure, other one is tissue tolerance. If you look into the pressure, that is because of the impaired mobility. If the patient is bedridden, and if the patient is not doing any activity, and if the patient is having sensory perception, impaired sensory perception, these reasons, the pressure is not accumulated unrelieved, they develop pressure ulcers. The other reason is because of the tissues tolerance. The tissues tolerance is because of two factors. One is extrinsic factors and intrinsic factors. It is in our hand again in the healthcare professionals. Nurses can prevent the extrinsic factors. The extrinsic factors are moisture, friction, and shear. If you look into the moisture, it is very common problem who have been an incontinence. The patient with incontinence, those who are wearing diapers. So the moisture can happen because of the sweat and the incontinence, and it removes the oil from the skin. And normally, this oil, this moisture protect the skin, it removes, and there will be connection with the connective tissue directly, and the patient will develop pressure ulcers. So that is what the moisture plays a major. Immediately you keep the skin dry. When it comes to friction, especially it happens when they do the bed making. So what happens when they do the bed making, they have to position the patient properly, remove the sheet. If the patient is lying down in a supine position, if the nurse goes and pulling the sheet just like that, and it creates lot of friction. So what happened, this friction occurs, there is a two surfaces, and especially from the sheet to the skin. And tissue tolerance, for this terminally ill patients, causing it's very less and causing lot of abrasions, and it causes no problem for the patient. And so that is the reason when the patient, slides down, reposition, should do it in a proper way, not do it in a wrong way. So again, that can be preventable. And when it comes to shear, there will be a rubbing of two fatty tissues, skin tissues across the bones. So what happens? It's a combination between, gravity and the friction. So it's very commonly occur when the patient is on head of the bed raised. If the head end is always is right, and will be the bone and the skin, both the thing will be having a shear. Okay, especially the spine may slide down in the bed when the skin and fatty tissues are stays in place. Okay, this type of force causes damage in the underlying blood vessels. So resulting a large area of internal tissue damage, and and the problem with this is it's less negotiable, and they don't see often. That is the reason they develop pressure ulcer. So as I said earlier, this is extrinsic factors can be prevented by the proper and good nursing care. And come to the intrinsic factors, that is because of the nutrition, the patient bed bound, less nutrition, demographics, some areas are very cold and everything, oxygen, hypoxic patients, skin temperature, chronic illness, all these things you can't prevent. The patient may get pressure ulcer It's our responsibility to take care of those pressure ulcers. So how the patient is developing pressure ulcers? All these risk factors. So whatever I said, no, either because of the pressure or tissue tolerance, on this area, the bony prominence. When the pressure, exceeds, okay, this exceeds more than a normal capillary pressure. Your normal capillary pressure is 35 mm of Hg in the blood vessel. If it is exceeds, there will be occlusion and tearing of the blood vessels. Then there will be a lack of tissue perfusion. So it lead into necrosis, and the patient end up getting a pressure ulcer. This is the basic pathophysiology, how the patient is developing pressure. You all know the common sites when the patient is in lying down. All the bony prominence under the skin will develop pressure ulcers. And you can see this is in supine position. All these areas, patient is in side lying position. Greater trochanter will be the greatest risk. And if it is in the patient prone position, even toes will develop a pressure ulcer. So this is based on the study shows which anatomical location among the patient develop more pressure ulcer. So the study shows that the patient in the sacral area, they develop more pressure ulcer than shoulder. So sacrum is the common area where most of the patient develop pressure ulcers. These are all the stages as per the National Pressure Injury Advisory Panel. There are 4 major stages: stage 1, stage 2, stage 3, and stage 4. Recently, it's not a stage. There are 2 other classifications they include. That is deep tissue injury and unstageable. I'll explain. The stage 1 is the skin will be normal. It means you can see only the redness, blisters, and non-blanchable skin. And in stage 2, there won't be skin. Skin damage will be there. There will be an open wound, and you can see the involvement of dermis and epidermis. In stage 3, skin loss, dermis, epidermis, you can see the muscles. That is stage 3. In stage 4, no dermis, no epidermis, no skin, and no muscle. You could see the bone. That much deep it would have involved. In the deep tissue injury, the skin and everything will be there, but inside everything will be damaged. You can see that the tissue would be damaged inside, but it's covered with. So it will be, purplish in color, and there will be, necrosis. And in unstageable, you can see there is necrosis, and the injury will be more. There will be slough, a scar, everything would be presented. How to prevent pressure ulcer? This is a very good scale, and you can use in a daily basis to assess the patient. This is the Brad and Risk Assessment Scale. You can know the scale help you to assess the risk, which patient is prone to develop pressure ulcer. So this is with the 6 parameters: sensory, moisture, activity, mobility, nutrition, friction, and shear. It's rated in 4 points. So it is, your total score is 19, okay, 19 to 23. And if the patient scores 19 to 23, okay, the patient, there is no risk of developing pressure ulcers. The overall score is 23. The patient scores 19 to 23, there is no pressure ulcer. If the patient scores 18 to 15, and the patient develops mild risk of developing pressure ulcer, the patient scores between 14 to 13, moderate risk. If the patient score 12 to 10, it's high risk. If the patient score less than 9, severe risk of developing pressure ulcer. So this is the rating. And if the score is more, and no risk. If the score is less, risk is more. Okay, this is vice versa. So you can remember in such a. So remember that overall score is 23. If it is 19 to 23, no risk. 18 to 15, mild risk. 14 to 13, moderate risk. 12 to 10, high risk. Less than 9, severe risk. So your goal, again, as I said, the prevention. So react to the red skin immediately, and check the skin integrity every day, daily examination, pressure relieving techniques. You can use, change the position and give extra pillows. I have, this is here, you can see 5 pillow rule. So 1 pillow under the one pillow between the ankles, one pillow between the knees, one pillow behind, one pillow under the head. So this is 5 pillow rule. However, you change the position of the patient, you can use this pillow to prevent pressure ulcer and make the patient to move. Mobility is very important. If the patient is bed bound, change the position mandatorily every 2 hours. If the patient is in wheelchair, every 15 minutes you have to change. Improve the nutrition and hydration. Minimize the extrinsic factors and educate the family members, which is very important because when the patient is in home care, right, as a nurses, what we do when the patients are in inpatient setting, we will, nurses are there, they go provide care, everything. But if they are in the home care, nobody will be there to understand why to change her. She's sleeping, she's quite well. So it is your responsibility to educate them why to change. Otherwise, see, more than the disease, the pressure ulcer will be killing the patient. So it is very severe condition. You can prevent it by proper education to the family members. This is the management. Once it is come, you can't do anything. You have to manage it. So stage 1, you know what is the symptoms. The patient will have pain, burning, itching. You can see the red dark skin. Clean the wound with mild soap and water. Protect the skin. Keep it dry. Follow the preventive measures. It will go by 2 to 3 days. And if it is stage 2, the symptoms are more. You can see the open wound, redness, pus will come. Okay, clean it with normal saline, and there are a lot of dressing materials available. Comfil is very good. Biotin foams are very good, and you can use for 3 days to 3 weeks. And if it is stage 3, you can use you can see the crater deep wound with a lot of drainage, exudates, everything will be there. If the patient in curative stage, they can go with the debridement. If the patient with end of life, you can only clean the wound and keep. You can also use alginate dressing, antibiotic, and special mattresses. Like it's mandatorily in every bed we use air bed. If the patient are well-to-do, they can go with the water bed. So the healing time is 1 to 4 months. If it is stage 4, you can see the black skin, deep wound, you can see the bone. Debridement, if possible, if the patients are good. Otherwise, you can do all others what you stage 3 and stage 4 same. It takes 3 months to years to heal. In unstageable, there is no proper exact, you can only keep the wound clean because it reached a stage where it will not heal. You can provide only comfort measures. So that is about pressure ulcers. Let me come to the other important in non-oncology setting, commonly they see the diabetic foot ulcers. So diabetic foot ulcer have a significant impact on why it is important, right? It is having a high morbidity and mortality. And because of the poor glycemic control, people will get absence of no proper wound care. So people will get this diabetic foot. So what happens, the patient quality of life will affect very badly. It reduces the life expectancy, increases the mortality rate. And if you look into that, there is no data actually regarding, can we provide diabetic care for things. But if you look into the epidemiology, as per the diabetic population, 15% of the individuals, they get diabetes during, and 85% will go to foot ulcers, and they also develop peripheral vascular diseases, and they become neuropathic, they go to neuroischemic and purely ischemic in diabetic wounds. And if you see the characteristics with this wound, frequently it will be, punch out appearance, I have shown in the picture, punch out appearance. You can see the peri wound, that skin and all will be very thick, which is called hyperkeratosis, anhydrosis of the surrounding tissue, and low to moderate drainages. But it's okay, but unless it is infected, and there will be lot of pressure or trauma, and they also develop as a vascular disease. Here the question is, okay, the patient is diabetic wound. Why we have to integrate palliative care for diabetic patients? Because the data study shows, because of this diabetes, The patient might, the incidence stored for, this is for shorter duration. This is for long duration chronic diabetes. The patient may develop cardiac disease, and the patient may go to the, look at the data, hypoglycemia and in end of life care, and the patient develop renal disease. They might go with amputation. They might suddenly get hyperglycemic events. So all these things are highly risk. And go through this study. This is a wonderful study. Sorry, this is a wonderful study. It shows, characterizing no needs of palliative care with the diabetic population. It's a very recent study in 2023. They have did. So they did a cross-sectional study in all the tertiary hospital for a 9 months of period, taking the patient with diabetic foot ulcer and non-diabetic foot ulcer, with or without. So if you see, the result shows only 10% of people with a diabetic foot ulcer, they can able to share the feelings with the family, and other people were neglected so much, they didn't get proper care. And that is the reason they identified the need of palliative care for both the group is very important, to address their physical issues as a priority and their emotional and psychological distress with this. And it has shown along with the active diabetic foot ulcer patients. So it is wonderful study. If you have time, please go through this study. I shared all my slides to palliative care team. They will share it with you. So your goal is again here is prevention, because prevention of foot ulcers with diabetes is extremely important, because it reduces the enormous burden of the foot ulceration. It's not only for the patient, even like us healthcare professionals, right? Our burden also will reduce. So you need to, create a evidence-based support for a patient and give a self-management protocol, which is very important. Do the daily foot examination. You can prevent it. You can teach the patient foot care to the patient, educate the family members to take care of the patient, appropriate footwear. It's often, some you have offloading devices are there, regular schedules. The patient has to visit the hospitals. This is the gold standard care. Maintain the sugar level, proper debridement of the wound, treat the infection with appropriate way, because patient may develop a sepsis and die, and reducing the friction and shear, as I said, friction and pressure in pressure ulcers, and adequate blood flow. These are all no gold standard protocol to maintain, manage the pressure ulcer. So this is the management pre-ulceration. As I said, all these things, self management, foot hygiene, medical care, all these things. And if you come to the ulcer management, start with antimicrobial antibiotic agents. And if it is severe infection, start with proper antibiotic. They need a hospitalization and local wound care, and better associate with the palliative care to provide appropriate wound management. So if you don't develop, they develop a peripheral vascular disease because of the poor, blood flow. And because these vessels are away from the heart, and especially they develop common in lower extremities, upper and lower. And you can see both, it is not only with this, both artery and venous insufficiency. So you can see in chronic venous insufficiency, the valves and veins are damaged, because why it is happening, the causing the blood pool into the veins and increasing the pressure in the veins. This results, there is a damage to the vein, and there is, because of the damage, there is a leakage of fluid and blood cells, and causing the edema and swelling. In case, on the other hand, arterial ulcers, what happened? They develop damage in the arteries, and because of the blood flow to the tissues. So arterial ulcers, also called a loss of, in the pain, worsened of the skin, and atherosclerosis, vasculitis, all these things will happen. So here, very common, what you see in a palliative care settings, and leg ulcers, very common. And it's because of the insufficiency. So how do we manage this leg ulcers? If you look into the epidemiology, 90% of the cases, they develop leg ulceration. And the patient, suggest because of leprosy, because of diabetes, because of venous disease, because of trauma. All these things they will show. And the causes, the mainly because of the age, old age, which is very common, and patient with a varicose vein, okay, the blood flow will stop and traveling backwards, it stop working, and lot of pooling of the blood, and it will distort the vein. And because of the tobacco, again, it affects the constrict the vessels, and arterial diseases, the other reason the patient will develop. Disorders like diabetes, very common, and arthritis, pressure ulcers, as I said, that is also a reason. And the medication. Some of the medications also contribute, if you see the patient with cardiac disease, they develop swelling and altered the circulation. Symptoms. So they look very asymmetric in shape, very sunken. Edges are not clear. You can't define it. Very intact, inflamed, and it's very hard. Hyperkeratosis, yellowish white exudates you can see, and particularly when the patient is having severe pain while standing, and varicose veins are very common. So your management for this is the cleaning the wound, proper cleaning. If the patient is to remove the debridement and something, it's okay, surgery to remove the dead tissues. Specialized dressings are available, and dressings, often changing damage the skin. So this Comfil biotin dressings are good, and compressions will be very much helpful for this patients to boost the internal pressure. Okay, there is wonderful study done very recently how the stimulating the muscle neuromuscular stimulation helps the venous ulcer to heal. That also I will show the evidence in my study. So this is by using generally you use the multiple layer. This study has shown they used extra 2 layers, so it shows lot of reduction. And the medications, you can use the proper pain medications and antibiotics for infection. And apart from that, adequate supplements like vitamins and minerals, all these things can be important. And skin graft, if the patient is curative stage, you can use. And in case of skin cancer or something, you are only able to manage the symptoms. And one more thing here is hyperbaric oxygen. I don't know. It's very common in Bangalore hospitals. Some of the multi-specialty hospital, they are using hyperbaric oxygen for diabetic wound and leg ulcers, everything. But it's very expensive. But you can see good results. But the wound should be very small in size. It should be, I think, 2 to 3 centimeter or something. If the wound size is more, and the effectiveness will be less. So that is what the study shows. This is the study what I was all talking about. So it is a impact of the intervention, the compression intervention. It is a randomized control study. So you can see this patient, okay, when they come for a treatment, after 4 weeks, okay, they stimulate the neuromuscular stimulation. So you can see how the wound, end of the day, how it has come after 4 weeks. So what they took 60 patients, adding the neuromuscular stimulation by multi-layer compression, and you can, significantly they increase twofold extra. So the wound healing over 4 weeks, you can see. So the margin and the percentage of area they measured, the graph shows, I didn't add that, the graph shows how much it has reduced the swelling also. So this is a very recent study in 2023 they published. So these are all about wound, the physical management. Apart from everything, how much ever physically the patient is well. Okay, the psychological issue. Imagine the patient with buccal mucosa. You clean the wound, there is no pain, no malodor, but still, I still remember one patient in my experience. This patient was 32-year-old male. He was with a huge buccal mucosa sitting on the bed. Every day when we go for rounds, he is first complaint to the doctor is, I have severe pain, manage my pain. Then she started pain management, everything. After 15 days, every day same problem. I have severe pain, I have severe pain. Then we called the counselor. We said that you please talk to that patient every day morning when we go, right? He's complaining of severe pain. Nurses also recording the pain as a severe pain. They said score to 8, 9, 10. They used to score. And the doctor is kept on titrating the medication. The pain has not come down. But when you look into the patient, you used to sit comfortably in the bed, say that I can't tolerate my pain. My pain is severe. Do something. Full of, that anger. But imagine if the patient with severe pain, unable to tolerate, how can he sit and talk like that? Then we thought counselor to talk. She had multiple sessions, and the counselor came and said, Madam, this person, before he developed this disease and the buccal mucosa, he was running a men's salon. So his primary job is to make the patient to get ready, groom well, take care of them, and all these things. And all of a sudden, when he got this, he just can't accept it. Okay, that is what I said, altered body image, which affect him so much. The one side full dressing, huge dressing, and one side I only open, he's talking to the doctor. And every 5 minutes, I noticed in the rounds time, he talk and used to see the mirror like this. That time we didn't, recognize why he is seeing the mirror. Then after the history and after counselor, then he said, throughout my life, I made others to look nice. Why I am looking like this, my body, why my face is like this. So you just can't, I can't travel anywhere. I can't talk to my, two young children. They can't come and kiss me. So this is what, you just can't accept it. These psychosocial issues are so much making you ill. So that is the main issue because of the wound. Women with the CA breast, the men with the buccal mucosa, and all these things, altered body image. And their sexual life, what it will happen because my loved one is not coming next to me, right? So the sexual life, fear of death, you do a wonderful physical management. You are an excellent doctor, wonderful nurse. You can do all the physical management. But whenever you go with the dressing tray near to the patient, when you open the wound, if they look into the wound, the death fear will come. That is the major issue. The patient will get lot of anxiousness, go into depression. They feel so shame to tell others and they will not involve into the society. They will be isolated. These are all the psychosocial issues when the patient is on a severe wound. And also a social problem. If the any of the family member has wound, you are traveling the bus and somebody is coming with a very bad wound, foul smell. What do? You step back, right? You don't go forward and do anything. So the social isolation is their family will not sit next to them because I told you the real life experience, the stigma, because it's not that voluntarily they do, they have that fear and stigma. They feel that either it is contagious and all these things you can see a lot of effects from the family. And as I discussed, sexual relationship, most of the time it end up with the marital harmony. And it also involved with the spiritual issues, interferes with the religious rights patient. Every Thursday I did a fasting. I went to temple. I was doing all the puja. But why I get this one? Is it a punishment from God? I will stop going to the temple. Okay, they have that fear, and there will be a lot of dilemmas. They'll find out the reason why I get all these things. Apart from all these causes and dimensions, your major role as a healthcare professional train the caregivers. Very, very important. Because when they are in our hand, we provide all the care. When they are go out of our hand, you need to train them, knowledge, their attitude. You need to understand their practice. Patient may be from poor socioeconomic background. You may do all kind of good dressing. They may not able to afford that kind of dressing, and if you say go and do everything, they can't do. Don't teach anything, show everything, because when you demonstrate, they will observe immediately. Do the regular follow up, kind of. If you have a home care facility, instruct the home care team to follow up and plan the goals of care. Why it is important, why they have to make a proper wound management, and teach them the small steps how to prepare normal saline, dressing materials, and all these things. It's all in your hand. Once you do the proper assessment, make the diagnosis, plan your dressing. Okay, it should not hurt the wound. The dressing should not hurt the wound. It should occupy full space. You have to maintain the moisture balance, protect the entire skin, and you have to do no proper dressing and secure it with the bandages, right? And you know how the patient to take care when they are bathing, pain management, and always address the underlying cause. If you design in such a way, you can do effective dressing for the patient wound management. So the bottom line is clean the wound, cover the wound, moisture it, waterproof, and protect it. So the key message for today's session is examine the whole patient. Don't treat treating the cause is patient centered is very important. Before you see only the whole, you have to see the whole patient. That is what the uh, core principle of palliative care, holistic approach. Thank you very much. This is what my talk of today wound management. Let us go with the case presentation, and if you have any doubts and clarify. Shall I stop my screen sharing?
Yes, Sister Sangeetha, thank you so much for that wonderful presentation. We have a few questions in the chat box. Maybe we can take that for a few minutes and then move to the case presentation.
No, I can't hear you. Yes, tell me. Because the flight was going here.
Can you hear me now?
Yes, I can hear you.
Yes, so we had a few questions in the chat box. I can read it out for you. And then
Yeah, but
after
I
we
am not
answer
seeing
that,
anything.
maybe,
I'm not seeing
yes,
anything
I
in.
can read it out for you, ma'am.
Yeah. Yeah.
So the first question was from Dr. Aditi. She was asking whether she can get the video of making of charcoal.
Exactly. I will share. I have a wonderful video. I'll share it with you people. You can share it to the team.
Okay, thank you so much, ma'am.
Yeah. I
And Dr.
made
Dilip has
personally in the
asked,
hospice. Yes.
so the next question is from Dr. Dilip. He is asking, local turmeric quality may not be too good. Any grade of turmeric that you use for dressing? Can you please tell about that?
Yes. So the turmeric powder, whatever is available in the market, we buy, and we will send it for autoclaving. After autoclaving, we will use it for a wound dressing. So put it in the steel container, seal it well, send it for autoclaving. Then once it's autoclaved, then you can use it. That's how we will use.
Okay, ma'am. The next question is about, can you please explain about the unstageable pressure sore?
Yes, unstageable pressure source is all about already the patient stage 4, the patient bone will be involved. Along with that, the patient will have lot of slabs, lot of scar, and there won't be any possibility of healing those pressure ulcers. At least in the stage 4, you can bring back to stage 3. But in case there is no healing possibilities with this wound. So here your only management is keep the wound clean. That is what you can do when the patient is on end of life care with the unstageable wound.
Thank you, ma'am. I think with this, we can move with the case presentation for today. And
Sure.
after the case presentation, we can proceed with the discussion. I welcome Dr. Vincent Krishnata for the case presentation. Over to you, Dr. Vincent.
Afternoon, Dr. Hasmat. Good afternoon, Mrs. Sangeetha. Can you hear me?
Yes, we
Yes,
can
yes,
hear
I
you,
can.
doctor.
Okay. My name is Vincent. Good afternoon. I am from Indonesia. I am an anesthesiologist and also an intensivist in a private hospital in Jakarta, Indonesia. I would like to present my case about a 72 years old male with diabetic ulcer of the right leg, with osteomyelitis and also with type 2 diabetes and community acquired pneumonia and immobilization due to ischemic stroke. So the patient came with a presenting complaint wound on the right leg that is getting bigger and deeper over 1.5 months before the admission to the hospital. The patient also had a decreased oil intake since 1 week before admission, and cough with quite a lot of phlegm since 1 week before admission. This is the history of his illness quite long. Actually, this patient is our chronic patient. When I open his medical records, it's already since 5 years ago. The patient diagnosed with type 2 diabetes, and he went to our internist every 2 or 3 months. About 2 years ago, the patient experienced an ischemic stroke, which left his left body paralyzed, so it is difficult to mobilize, and it becomes more difficult for the patient to come to our hospital for treatment of his diabetes. Suddenly, around 2 years ago, he came to our hospital with an ulcer on his left leg that got so bad that it had to be amputated. The patients became more bedridden and didn't come to hospital again until about 2 weeks before the hospital admission. He came again to our hospital with a wound on his right leg since 1 month. This time, the internist already suggested amputation, but the family refused. But 2 weeks later, he came to our emergency with the wound getting smelly. The family finally give up and they came to our emergency. And by that time, the patient condition is already very weak, and the surgeon decided to delay the surgery. And we just did some bedside wound management on the ward. Next slide. This is the examination during the admission in our emergency room. So the patient is confused, weak, low blood pressure, slight tachycardia, slight tachypnea. There is a weakness on the left side of the extremity, and patient is somehow confused and unable to communicate with us. And there is also a slight tachy in both lungs. Next slide. Okay, this is the image of the wound. I'm sorry if it is disturbing. The location of the wound is near the ankle. The wound assessment is deep, necrotic with irregular shape. There is a foul smelling and presence of exudate. There was no bleeding, and the pain was difficult to be assessed because we cannot communicate with the patient. He is somehow confused. Next slide. This is the treatment of we give to the patient. First, during the hospital admission, the blood hemoglobin is only 6.6. Actually, we give some transfusion in here. The early treatment is just some bedside wound care. We gave him also some antibiotics, clindamycin and intravenous levofloxacin. We also gave him insulin, intravenous fluid therapy, and feeding by NGT. This patient was planned for amputation around 3 days after admission, but just 1 day before the surgery, the patient experienced a sudden dyspnea and desaturation. So he was intubated and referred to our ICU. We gave him mechanical ventilation. However, after the discussion with the surgeon, we decided to proceed with the surgery because it is for the source control. We gave him general anesthesia and he had unstable hemodynamic during the surgery that need a vasopressor. I'm the one who gave anesthesia for him. Uh, After the surgery, the patient condition is getting worse, maybe due to septic shock. We gave an increased vasopressor dose. Also, the antibiotics, we give an intravenous meropenem. However, after all our effort, the patient died just 2 days after the surgery. Next slide. For the psychosocial aspects, our patient is a 72 years old elderly man living with his youngest daughter. He came from low economic groups and his wife was deceased several years later. He has 2 sons and 1 daughter, but the 2 sons working in other cities, so they didn't take part in taking care of him. He has been bedridden since 2 years and he doesn't work anymore and got money from all of his family. So far, the treatment in hospitals was covered by our government welfare insurance, but treatment at home was not covered. And according to his daughter, the patient in-house daily could communicate with her, but sometimes he seemed confused. This is the medication, the list of the medication that we gave to him. During the admission until 3 days in the ward, we gave him bedside wound care using chlorhexidine soap and normal saline. We also gave him topical gentamicin. This is the most commonly used topical antibiotics for wound in Indonesia. We also gave him clindamycin, levofloxacin, paracetamol, omeprazole, ondansetron, insulin, lingalactate, feeding by NGT, and red blood cell transfusion. Later in the ICU, we gave him mechanical ventilation due to his sudden dyspnea, and we proceed with below knee amputation as a source control surgery. And we also gave him norepinephrine and IV meropenem later in the ICU. Next slide. The main concern for this patient was a worsened diabetic ulcer that lead to sepsis and finally lead to septic shock. This is a bedridden and I think a bit neglected and the elderly patients and of course of financial problems because he came from low economic groups. Next slide. As the summary, this is a 72 years old elderly man with chronic type 2 diabetes and a history of stroke, suffered a diabetic wound on his right leg, which results in sepsis condition, which then required an amputation. However, it was too late to treat his condition during that time, so after the amputation, his condition worsened and he eventually died. I think that's all. As the discussion point, how can this one be managed effectively? How well could we have managed this patient under palliative care? And considering that this patient died in the end, what are the things that can actually be improved? I think that is all. And before giving any comment, wait, I
Yes.
post something.
Thank you,
Sorry.
Dr. Vincent.
Yes.
Yes, thank you so much for bringing this wonderful case for presentation. So meanwhile, I want the participants also to post your comments and suggestions, and then from there, Sister Sangeetha will also be there to help you on how well this could have been managed. So initially, Dr. Vincent, Dr.
Yes.
Dilip is asking, should the surgery for amputation be delayed? Still, the patient was stabilized. Initially, it would have been better to manage the wound conservatively.
Yes. Our discussion with the surgeon decided that because the wound was very bad and there is a push, if I'm not mistaken, we decided to proceed with the surgery because an initial conservative wound treatment doesn't give us a very good result. And after we discussed also with the family, we decided to take the risk to proceed with the surgery because the patient already in the ICU and already intubated also. I don't see any reason to delay the surgery. It's already delayed 3 days since the admission to the emergency. And for the treatment of sepsis, the main treatment is wound source control is the main treatment for sepsis. I think that is for Dr. Dilip. Thank you for the question.
Thank you, Dr. Vincent. Sister Sangeetha, please add your comments.
No, I just wanted to ask Dr. Vincent. So,
Yes.
based on the presentation, you listened about how we will manage the wound in palliative care settings. Now, tell me, after seeing this, how could have been managed effectively? You can answer the questions now. What do you think now? So, this is what happened to the patient. Okay. So, from now, just tell me how you could have managed effectively.
After I have some knowledge from you, Mrs. Sangeetha, actually this is a very late treatment for this kind of wound. If I have the chance, actually the treatment should be start several years previous before the patient came to our
Excellent.
before the patient came to our hospital. Maybe by the time he had a stroke when he was bedridden, we should already start palliative care in there. We should anticipate any risk of getting the wound because this patient is very high risk of getting any diabetic wound or partial ulcer like that, Mrs. Sangeetha.
So the thing what I wanted to suggest here is the first thing in this one in your case, he's a chronic patient. You saw
Yes.
this patient 5 years ago.
Yes.
You had a long time. And if you see, that is what the lack in palliative care, early recognition, right?
Yes.
As you
Of
said
course.
rightly, after this session, you have to recognize early and refer to the centers. So you could have prevented the complications. See,
Yes, of
here in
course.
palliative care, we are not going to, take away the diabetes or take away the stroke, or we are not going to do anything. But what happened? You can prevent all these complications. See, he just came to you with only diabetes, and he developed the ulcer in the left leg first, and went with the amputation, and again post-op surgical complications. Again developed a right leg, and again you preferred for amputation. Family financial problem, family burden, sons were not nearby, only daughter has to support, right? There is lot of burden as a caregiver, and every time approaching to the hospital, you think about from the caregiver perspective, the only lady, has to bring the
Yes.
father to the hospital, and she will be having her family, her children are
Mm.
working, and
Yes.
thinking everything, lot of complications as a professionals we created. So once you refer, and where is the home care involvement? Right.
Yes.
You don't
Yes.
have to ask the patient to come. At least if you outsource, if you one link, if you have done with the palliative care team, they would have suggested with the home care teams. So the team will go and address the patient. So you could have avoided all these complications from the early, and end of the day, you could have provided a quality of life instead of patient. When I was listening this case, 5 years of suffering. It is not that
Yes.
2 or 3 days of 5 years of suffering, 2 years completely bedbound. End of the day, he lost both the legs. Okay, what kind of life he lived, what kind of dignity he had in a life. So if you put all these questions in front of you, so this is what says the importance of palliative care. One of my slide, I told you very clearly why it is to integrate palliative care, especially for diabetic ulcer, because you don't have lot of evidence. This much of population, this much came into this, but your case has proven this today. Right, it was a wonderful case what you presented, and the team will understand because the focus is more on malignant wounds. Apart from that, this is also diabetic foot ulcers also equally complicated to the malignant wounds. That is what I'm telling. It has to be effectively managed if you would have done one point link with the palliative care team, because you know very well it is a chronic. Okay, it is not a problem which is going to solve immediately. Diabetes, it is a chronic diabetic. It goes, and we don't know the exact data about the diet management with the patient, right? You don't know what are all the diet management because the patient underwent lot of complication. If you would have given that self-education, and I know as a busy physician working in the ICU, you'll be very busy all the time in the emergency. If you would have given that responsibility to your supportive care, they would have taken care of patient education, family education, and the symptom management, and talking about the quality of life and controlling the symptoms. This would have been done. That is what your second question answers, how well the patient will be managed under palliative care team. So he would have lived his life. The patient would have good mobility. He would have not lost his this one legs. And I have also seen this one in your medications. There is, you added gentamicin, you have clindamycin, all these things. Here, in case of sepsis, infection, we prefer metronidazole. So giving me, as I said, the sniff, you explained about the patient with foul smell, exudates, and all those things. What about the sniff ladder? So these are all how the team is efficient in managing these cases, right? So that is
Yes.
what here again I'm insisting the patient, though, so okay, early recognition is always a question. And one more skill of the palliative care physician and nurses is anticipating. So they are excellent in anticipating what's happening tomorrow. They will not see that the patient. As a nurse, I will not see, okay, the patient is with this problem, I'll prescribe antibiotic. How the patient will be tomorrow? So this anticipation, that clinical skill is very efficient for the palliative care team. That you should learn in this basic session. How you can anticipate the patient problems, how you can anticipate and start your prescriptions. All these things would be very helpful, and you could have done a lot with this patient. Now, I feel somehow I lost this patient, right? We could have done a lot with this patient. At least in future, these are all the things. If at all you don't have time, you just link it. It's a small job. Refer to the center, your job is over. So whatever it may be, curative management you do. So I think this one as a curative management, you can control your diabetes, you can manage all these things. Other side, they will take care of all the wound management, other symptoms, all these things.
Okay, thank
That
you,
is
Mr.
what
Sangeetha.
I thought of telling to you.
Yes. Actually, in Indonesia, we don't have any palliative medicine specialist or nurse or something like that, ma'am. So most some hospital have palliative service, but they usually run by anesthesiologists, by oncologists, internists, or anyone interested in this field. And this doctor usually learn palliative service by themselves about maybe in Malaysia and Singapore like that. So palliative medicine is something new in Indonesia.
Okay,
We don't have
I
this
can
therapy.
understand. So what I can suggest, the place like us, like if you approach Pallium, okay,
Hmm.
if at all you don't have centers, they will refer
Hmm.
to some of the centers where you can talk to the palliative care physicians referrals. You can
Hmm.
consult with them, tell this case what I can do. In that way, you can help the patient. So it's very difficult, right? We don't have centers, we can't, but
Hmm.
that should not be a reason for the patient to die,
Yes.
right? The patient to suffer. So we should find out a way how we can provide comfort and quality of life to the patient. So we are also a supporting center. If at all you call one of us, one of the doctor, we will help you, to provide the protocols, like manage like this. So over the weekly once or weekly once in 2 weeks, we can have a small discussion how the progress of the patient. That would be helpful. Kindly teleconsultation. We can do the teleconsultation. Would be helpful as a consultant. You can consult these people and take a reference.
Thank you,
Yes,
ma'am.
that's wonderfully put up by you, Sister Sangeeta, because I think she has covered every aspect of how this patient could have been managed. And she was mentioning about the teleconsultations. Yes, definitely you can reach out to organizations. Even Pallium India has a telehealth helpline, which supports healthcare professionals in managing their patients. So from Monday to Saturday, the helpline is from 9 to 5 p.m. You can call us on the helpline. The doctor is always there to give you inputs on how to manage a patient. If you are in such situations, challenging situations, we are always there to help. And yes, that was wonderfully mentioned by Sister Sangeeta also. So I would like to tell that here. And also the importance of early integration of palliative care, that is the most important thing that I was about to see particularly in this patient story, because that is very much needed. As we can see, even in India, the non communicable diseases are on the rise, and by 2060 we can see that there are several studies which says the non communicable diseases will be reaching its peak, and there we need to understand the importance of palliative care, because once it becomes a serious health related suffering, we actually need palliative care people to come in to pitch in and do a lot of things. So even now there has been a misconception that palliative care is only for terminal care and for end of life care, but no, it is very important that we have to start like integrating palliative care right from the beginning. So that is one learning point, I would say, especially for this patient story that you have brought in, Dr. Vincent. Thank you so much for your wonderful comments. And participants, if you have more questions, please feel free to raise your hand and ask your questions to Sister Sangeeta, or you can even post in the chat box. I was able to see few comments where the doctors had mentioned about diabetic food care. Is definitely that is very important. Proper diabetes control and skin care is important for this patient. And we need to check adherence of medications, the compliance to medications. Dr. Rosa has mentioned that's really good, because most of the time we miss that. And Dr. Kalyani has mentioned it's a very appropriate case and good discussion for today's topic. Thank you for that comment. I give that credit to Dr. Vincent. And yes. So apart from that, any more questions? Please feel free to ask.
Metrogyl ointment is also coming. So, what is the difference between applying ointment and powder?
The thing is the cost effectiveness. So it will be the same effect, but the ointment is bit expensive. So get a tablet and we use it. That is the only difference. So if it is the patient affordable, the urine incorporates, and you can use metronidazole ointment. It's good.
Okay. Yes.
Yes, there is a question. Yes, metronidazole works always better for foul smell. That is what the study I have shown. So how the metronidazole effective to control the foul smell? It's a proven research study. So all palliative care professionals, we are using it as a standard order.
Yes, yes. Because even in our inpatient units, we have used injection metronidazole as even
Yes.
nebulization
Yes.
for wound management to control the foul odor, and also
Yes.
injection metronidazole over the wound for the foul odor. So it has been really, really having wonderful, results. We have seen wonderful results, and we have been using even before when I came into palliative care. Even I was wondering with such questions whether metronidazole really helps, before I joined. But now I really know that it really helps a lot because we have
Exactly.
been using it on a regular basis.
Yes, yes, correct, Dr. Rashmi. It's not only on the wound. If you see the halitosis with the patient, you can tell the patient to gargle with metronidazole, then gargle with normal saline. So what happens? That foul smell drastically will reduce. So that much the metronidazole is effective. As Dr. Ashmat said, injection metronidazole, you can tell them to gargle and split it.
Yes. Any more questions? If I couldn't see anything in the chat box, but if there are any more, we are there to take it up.
Hello, Dr. Ashmat.
Yes, Dr. Kalyani, please go
Yeah.
ahead.
Sister Sangeetha, Dr. Hashmat, we come across a lot of ointments and gels. For example, one there is debridase containing urea, then another mega heal gel, and we also come across Vaseline gauze pieces.
Yes.
And I recently came across a new dressing that one of the patient itself showed me and asked whether we could use it for bedsore dressing. And that was some occlusive dressing. I forgot the name now, but it was such dressing that we had to do it once in 15 days or something like that.
Yes, kind of alginate dressing, foam
Algin-
dressings. Yes, alginate dressings are very good. You can use twice a week, and bio bio biofilm dressings can be used for 7 days once, because to avoid a skin irritation, right? If you do regularly remove and take it, these dressings are very effective and control the pressure ulcers. And as you said, you mentioned about something you mentioned.
Debridase.
All
Debridase.
these ointments are very good in healing pressure ulcers. Even we use Meha Heal and Debridil, Healase, and all these things. But when it comes to the financial aspect of the patient, because when I talk about the dimensions of palliative care, it's not only physical, psychological, social, spiritual. It is also in India economical. You should see
Economic.
that. And which cost 2,600 rupees Healase, and again think about the patient cost. So based on the socioeconomic background of the patient, you can plan it. Otherwise, go with the cost effectiveness, no? Using preparing a metronidazole gauze charcoal dressing would be helpful.
Sister Dr. Hashmat, if such a PPT or some data was available regarding all these ointments or dressing in one place, if possible, if it is available, please could you send it to us? If there is a compilation of such ointments and dressings.
Sure.
Definitely,
Yeah, yeah.
Dr. Kalyani. Yes,
Yes.
we will look into that and get back.
But what I'm thinking,
Thanks.
Dr. Ashmat, we can make like a guideline, okay, small algorithm, and we can share it with them.
Okay, okay, Sister Sangeetha,
That
definitely.
would be good.
Yes. So there was one more question asking about the composition of alginate dressing.
I'm not very sure about the composition. I'll find out and share it with you.
Okay. Thank you, Sister Sangeetha. And especially when Dr. Kalyani was asking about debridase and mega heal, usually for pressure ulcers, we personally prefer using debridase for areas where there is slough, and surrounding the region there will be granulation tissue, healthy
Yes.
granulation tissue. There we encourage using mega heal. That
Yes.
is how we do the dressing. We
Yes.
ask the patients to apply it that way.
Yes, yes, we do the same.
Okay. Thank you, Sister Sangeeta, for patiently answering all those questions and for, putting up everything in a very wonderful way. I really enjoyed the entire session. It was really very informative. Just that I couldn't keep my video on today because I'm working out of office and I have a network issue. That's the only reason I couldn't keep it on. But it was a very wonderful session. Thank you so much, Sister Sangeeta, and to Dr. Vincent for bringing in a wonderful case for presentation and the participants for being really very interactive. Thank you so much, and I hand over the session to Gayatri.
Thank you, Dr. Ashmat.
Thank you so much, Sister Sangeetha and Dr. Hashmat, for the wonderful presentation. And I hope that the insight and knowledge shared have been both informative and enriching. Thank you all participants for the engagement today. And hope you and also have a wonderful day ahead. Thank you all.
Thank you, Gayatri. Thank you, everyone.